Everyone hear me okay? See me okay? Okay, great. If you have any difficulties, please feel free to use the chat. Stephanie is my co-pilot and the kind of tech extraordinaire here. And so if you have difficulties hearing me, hearing sound, I'm going to play a little bit of a video. Just let her know. If you have any questions that are coming up for you as we're talking, please also feel free to drop those in the chat. I may not have time to address each question as they come up, but as long as we have a place for those questions to live, I will try to get to them either by the end of the session or by the time we meet again next week. So as things come up for you, please feel free to jot them down. I'm Dr. Green. I'm a licensed clinical and community psychologist. I'm actually located in Atlanta. I own a private practice. I also am an adjunct professor. I do many other things. And today I'm here to talk to you about cognitive behavioral therapy in real world settings. I know that we have a mix of folks who are on the call, and my session today is partly geared towards thinking about the foundations of cognitive behavioral therapy, what we really need in order to do it well. But the other part of the talk is really about you talking to each other, answering some questions about how to consider implementing programs into your particular environments. You know much more about your organizations and their cultures than I do, and often we learn so much by talking to our colleagues. And so I want to give you the time to do that rather than just listening to me. So we're going to go ahead. We're going to get started. Before we go any further, I do want to declare I don't have any conflicts of interest, just so folks know. I'm going to share our objectives, and then I'm going to actually start with a reflection. And I like to start all of my talks with reflection because we are the tools of the work. No matter what our orientation, no matter what skills we're bringing, if we are not clear about who we are when we're showing up as leaders, as clinicians, as providers, then that can sometimes interfere with the efficacy of the work that we're doing for our clients, for our staff, for our colleagues. And so we're going to start with a reflection after I talk about the objectives, and then we will get into the rest of the presentation. So I'm going to go ahead and share my screen. Okay. And of course, okay, good. All things are not where I need them to be. All right, perfect. So I hope today that we will do some receiving of a refresher of the foundations of cognitive behavioral therapy. I want to introduce the role of implementation science when considering using CBT. I'm not going to be very jargony, which I know sometimes researchers and program evaluators can get. I'm not going to do too much of that, but I do want to introduce some definitions that I think will be helpful for framing our conversation today. And I want us to do some collaborating on problem solving and thinking through some of the most important factors when considering what kinds of programming to bring to your organizations, and when considering how you're evaluating whether or not something is working, whether or not something is a good fit. So if folks could just kind of drop in the chat, if you are a provider, just kind of put the letter P. If you are in administration or leadership, if you could put A. And if you are both a provider and an administration, just put AP. Just want to kind of get a sense of who's in the room. Okay, perfect. So we have a pretty good mix. We're pretty split. So the next group of questions, if you're someone who is in the provider role, these are for you. If you're someone who is an administrator and provider, you can choose whether or not you want to answer the first group of questions or the second group. It's up to you. I'm going to offer 3 questions, and I'd like you to offer 3 words for each question. Off the top of your head, don't do a lot of thinking about it. There's no wrong answer. Once you come up with the words, though, I'd like you to drop them in the chat. So this is about not only listening to our clients and our colleagues and our staff, but also listening to ourselves. That's where we start. For providers, how do you want your clients to feel after their first meeting with you? 3 words. And how do you want them to feel after their last meeting? We often don't think about the last meeting when we're at the first, but I'd like us to consider, how do you want them to feel when they walk out of your door? Treatment is concluded. And what are three essential aspects of the treatment and the environment that need to be true in order to achieve those goals? So I might say when I first have my clients meet me, I want them to feel seen, heard, and appreciated. When they leave, I want them to feel empowered, resourced, and confident. Three essential aspects of treatment. I want treatment to be challenging, I want it to be compassionate, and I want the environment to be welcoming, for example. Okay. Administrators, how do you want the culture of your organization to feel to your staff? Again, three words. I want staff to feel maybe seen, heard, and appreciated. And then how do you want the organization to feel to clients when they walk in the door, when they're talking about services they've received? What do you want them to say? And what's the lasting impression that you would like the organization to leave on policymakers, funders, decision makers, even community members? So these are folks who are not necessarily engaged in services, but they are still stakeholders. What do you want them to say about the organization that you are part of, that you're leading? Let's see what we have. So from the provider perspective, we have words like relaxed, heard, understood, supported, hopeful, seen, understood. That's a big one. Safety, relaxed, accomplished, satisfied, validated, heard, heard, heard. Heard is very big. Support is very big. Comfort, hope, these are very big. Inspiration, motivated, want to be seen as resourceful and supportive, a safe place. Resourceful, productive, glad. Okay. Okay. So it sounds like whether you're sitting in the provider role or the administrator role, there are some commonalities between how you want clients to feel and how you want staff to feel. And so I'd like that to be the backdrop to the conversation that we're going to have today. Because whether we're implementing cognitive behavioral therapy, dialectical behavioral therapy, mindfulness, or anything else, the context in which the environment is the context, sorry, in which the intervention is happening really informs the efficacy of the intervention and how well clients are able to receive it, how well service providers are able to deliver it. And it also informs the relationship between leadership and providers, leadership and clients, leadership and the rest of the environment, including the community and their stakeholders. Let's talk a little bit about foundations of CBT. So cognitive behavioral therapy is founded in cognitive theory. And cognitive theory really recognizes the mechanism for behavioral change at the thought level. Cognitive behavioral therapy is well researched. It has a very robust literature backing, randomized controlled trials, which are considered the gold standard of research that show its effectiveness for treating a variety of psychological disorders, including anxiety, depression, varying psychosis, sleep disorders, and even other disorders outside of the realm of psychology. Lots of mood disorders, pain, how you think about something and impacts how you feel about something, which impacts your behavior, which we know extends beyond just psychological health and well-being. And so cognitive behavioral therapy is a really natural choice for any clinician or any administrator that is looking to bring an effective intervention to their environment. And we can think about the mechanisms of change as not only living in cognitive restructuring, and challenging, but also recognizing that there is a behavioral component to cognitive behavioral therapy. The cognitive theorists recognize, you know what, we can do a lot of thinking, we can do a lot of talking, we can challenge what people believe, but if we don't also give them tools for shifting their behavior, then we're kind of only addressing one piece of the puzzle. And we can have behavior change without necessarily shifting cognitions either. And we need to have a way to find both. And so cognitive behavioral therapy really seeks to marry both cognitive restructuring, challenging unhelpful thinking patterns, really creating alternative ways of perceiving the world, oneself, relationships, and it marries it to active behavioral activities and changes. Cognitive behavioral therapy is actually a pretty structured intervention and really encourages providers to help clients become aware of their own internal processes, particularly from the place of what they're thinking about. And I think it's important to recognize that clients' core beliefs, their automatic thoughts, have origins not just in intrapsychic processes, but in their values. And I found that for me, although cognitive behavioral therapy, as far as I know, doesn't explicitly talk about the importance of values, it is important to bring values into the room. My background is in working with trauma in particular. And most recently, before my private practice, I was a part of the military sexual trauma team at the VA here. And one of the things that we found when utilizing cognitive processing therapy, which is essentially CBT for trauma, is that sometimes when we would challenge and push back against some of the stuck points or the automatic thoughts that our clients were coming in with, we would be met with a bit of defensiveness, some resistance, right? There are some thoughts that clients actually felt quite attached to. And we found that within the stuck point, a stuck point might be because I was assaulted, I am no longer worthy, or I'm no longer pure, for example. Within a thought like that lies a value on the other side. There's something there about what this person may have thought about the meaning of sex and sexuality, the meaning of their particular sexuality, the meanings of violation and how those meanings are intersecting with who they are in the world. Many of the folks that I saw were African American women. And so I was really thinking about what are the values around sexuality and female sexuality and Black womanhood. And all of those are coming out in these stuck points that are interfering with these women living lives that are fulfilling, meaningful, and really kind of absent of significant PTSD symptoms. And so really locating the values that are present for our clients and recognizing that values are guideposts and that values can show up in their opposite when we're looking at some unhelpful thinking patterns and cognitive distortions, I think can be a really comprehensive way of approaching some of the cognitive restructuring and challenging that we have to do in CBT. It also helps us to recognize why some folks might hold on to certain kinds of thoughts over others, because some thoughts might actually be in line with some values that they hold, even if those thoughts are not necessarily helpful for them. So for example, more goal-oriented people may be more prone to value achievement over acceptability. And so we might want to move our clients towards accepting something, but what they want to do is conquer because they believe in success and achieving and moving forward, and acceptance might seem like complacency, for example. And so really paying attention to where are the values here and how are the values either helping treatment, hindering treatment, or informing our clients' experiences. Really paying attention again to where core beliefs, automatic thoughts come from beyond intrapsychic processes, beyond developmental environments, and really acknowledging and noticing the ways in which educational environments, religious institutions, the societal soup in which we all live impact how we think, how we engage with one another, media, marketing. All of these pieces are really important. Socio-historical context, the values and norms that we pick up from our family environments, from our cultural mores, and really bringing those into the room also so we can expand our understanding of cognitions beyond These are the thoughts that me as an individual in the world is having, and recognize that these thoughts are informed by and also inform my experiences of the world. Recognizing that my thoughts are dynamic as I am dynamic, and really kind of bringing that into the work that we're doing. Of course, trauma informs core beliefs and automatic thoughts, and paying attention to questions like, when did you first start thinking of yourself this way? When did you first start thinking of this way? And also questions around memory. Is there a memory that's attached to this particular way of thinking? Are there particular memories or people that can give us kind of more information, which can then help us understand more about where these cognitions are and what they're really about and getting to? The therapeutic approach for CBT is really structured. And I think this is a really important part, because not all providers approach treatment the same way. Some of us are more semi-structured. Some of us really like to sit in the seat of exploring and letting the client lead. And CBT says the provider is kind of the teacher. You are providing psychoeducation, you're holding the frame, you're setting the agenda, you're making sure that the client is doing the homework. If they're not doing the homework, you're thinking about ways to keep the client accountable. You are putting together plans to make sure that the homework is done, because we're trying to achieve goals. We're being goal-oriented, we're being structured, we're informing the client every step of the way about what the agenda is. And our goals are very specific. They're smart, specific, measurable, attainable, are realistic, and time oriented or time bound. And it's really important that the goals are set up this way, because those aspects make goals more likely to achieve. So for example, if I have a client who hasn't exercised in 6 months because their depressive symptoms have been really taking away their motivation, I might say to them, okay, let's create a plan for you to exercise again. And they might start out by saying, well, I want to exercise more over the next month than I did last month. Great. That's not a goal. We have to get very specific. What do you mean by more? Okay, well, I want to exercise 3 times a week. Okay, well, how long? Well, 3 times a week for 30 minutes. What kind of exercise? I think I'd like to run. Okay, well, where are you going to run? I'm going to run in my neighborhood for 30 minutes, 3 times a week. Okay, well, what time of day? I'm going to run for 30 minutes in my neighborhood in the mornings. Really getting as specific as you can about what the goal is and all of the pieces that are needed to know what we're really measuring can really make it easier to do the second part, saying, I want to exercise more versus I want to exercise 3 times a week. That's something that's measurable. Now, is it attainable? In my neighborhood, I live across the street from horses, and so we don't really have sidewalks. I might want to run 3 times a week, but running 3 times a week is somewhat putting my life in my hands if I'm running in the street. So are the client's goals matched to the environments in which they live, or what is accessible or attainable for them? I might have to say, okay, well, I want to run 3 times a week, but I have to find a safe place to do it. Maybe I need to go to a Y that has a track. So really helping clients think through what are the ways in which this goal can be most attainable, which of course aligns with whether or not it's realistic and time bound. I want to make sure that I am achieving this goal within the next month, right? So we can measure at the end of the month whether or not that goal has been achieved or how well that goal has been achieved. What I like to do with my clients, especially my folks who might be experiencing significant depressive symptoms and also anxiety actually, is I like to have them identify a SMART goal and then identify, well, what happens if we can't do that, right? If we can't really do 3 times a week running, what's the like minimum that we can do? What if you really don't feel like it? You really don't have any motivation. We can't do that. And I said, well, okay, well, maybe I can do 10 minutes. I can do 10 minutes 3 times a day. And maybe I can't go to the Y, but I can get out of my bed. I can roam the house for 10 minutes. And so that's not really the goal, but that's like the secondary goal, that if we can't really do the top, we can at least do that next piece, because that can make the goals even more likely to be achieved. And so as we are thinking about what the therapeutic sessions look like, it's really cognitive, it's really practical, it's really hands-on, it's really accessible. And so some of our clients are really well-oriented towards being goal-directed. I have people who call me up and they say, I want tools, I want resources, I want to see these kinds of changes. We have other folks who might actually be much more ambiguous. about what they want and what they need. They might be experiencing kind of general life distress. And so having them get specific about their needs might actually take some time. There might be psychiatric symptoms that are interfering with them having that kind of clarity. So that actually might make it more difficult for clients to be more specific. And again, providers might be oriented towards partnering with clients in an exploratory process more than moving directly towards a goal. And so really thinking about what is needed to maintain the frame, the structure, and the container of a cognitive behavioral framework is really important when thinking about the appropriateness of CBT for your particular environment. Of course, the expectation is that treatment will be short-term, 10 to 12 weeks, and that it will eventually taper off. There are some interventions that are even shorter. When I first learned cognitive processing therapy, we had a 12-week protocol. Now there are protocols that are as short as 7 weeks. And so we're talking about a pretty quick turnaround in some cases. Here is a model that I think is just helpful because I like visuals. And I think one of the things I really like about this model is that the only unidirectional arrow is from the situation to thoughts and cognitions. All of the other arrows are bidirectional. Now, if we look at a thought record is column by column by column, right? We start with what is the activating event or what is the prompting event. And then the next piece is, well, what did you think about it? And then the last is, how did you feel? But this model helps us to recognize that we don't always start with thoughts. Thoughts are not always the most accessible. We might feel something first. We might notice a sensation before we have a name for it. We might behave a particular way, and you might ask the client, well, why did you do that? And the client says, well, I don't really know. And so we might have to use behavior and go backward as a way to learn more about how the client got there. And so I really like this depiction because although cognitive behavioral therapy might give the impression that our experiences and our clients' experiences are progress in this kind of logical way, the reality is often messier than that. And so when we think about depression and CBT, the tools that we often use are really directed at challenging fundamental beliefs that are about the clients themselves, the future, the world. Often clients believe I'm terrible, I will always be terrible, and no one cares about me. And so we are fundamentally trying to shift those beliefs using tools that are helping clients identify automatic thoughts, the downward arrow technique, right? How did you get here? Let's go further, further, further down. What's at the base of that? What's the core belief? Socratic questioning from an exploratory and curious way, helping clients to identify thinking errors or cognitive distortions, black and white thinking, minimizing, catastrophizing, and also helping clients to keep track of what they're thinking. And cognitive restructuring is really recognizing that when we help clients to become the expert of their own internal experience, they have more ability to shift what's happening. They have more ability to become curious about, well, why do I think this? And where does this come from? And what evidence do I even have that this thought might be true? And if I don't have evidence that this thought is true, or my life is teaching me something else, what is another way for me to be in the world? When it comes to thinking about cognitive behavioral therapy and anxiety, which is another frequent intervention that is utilized for anxiety, CBT is targeting really common errors in thinking. Probability error, right? How likely it is that something is going to happen. And then if something does happen, how likely that it's going to be a catastrophe. And the likelihood that we don't have resources to meet whatever's coming our way. And so when we're dealing with cognitive restructuring and anxiety, we're often trying to help clients expand their understanding of probability in the world, of their place in the world in terms of being able to manage distress or uncertainty, and helping them to also push back against worry. Mindfulness can be helpful here. Mindfulness is not particularly a cognitive behavioral technique, but it can be tacked on to cognitive work because it does also encourage the separation between the person and the thought. And so identity is one thing and thinking is something else, which can also be a place of great change. Of course, the cognitive theorists recognized cognitions, that's one thing, but we need this behavioral piece, as I mentioned earlier. And so for Disorders like depression, behavioral activation is often where we see a lot of activity around behavior. So we have activity scheduling so we can learn more about how clients are operating, and clients can also learn more about how they're operating. In activity scheduling, we also have the opportunity for clients to nurture more of the activities that are helpful for them and to do less of the things that are not helpful for them, helping clients to recognize that even getting up in the morning and brushing their teeth can bring a sense of achievement and a sense of contentment rather than staying in bed until 2 or 3 in the afternoon or all weekend. Behavioral activation also gives us as clinicians a really good way of keeping clients accountable to their own goals. And so if you said you want to get up and run 3 times a week, let's put it into activity scheduling. Let's see how you felt. Let's see what happened for you. I know that it was really hard for you to do it in the beginning, but afterwards, like, look at the difference in your subjective units of distress or your SUDS levels. You actually feel so much better, and you have many more days where you feel like you've accomplished something than the prior week when you were mostly in bed, not doing very much. Behavioral activation also gives clients the opportunity to engage in behaviors that are self-reinforcing. And so the behaviors themselves become rewards. And that's something that I'm actually quite explicit with my clients about, because often they tell me they don't feel like doing whatever it is that we are talking about them doing. And so I recognize that and sympathize with them, and also educate them about the danger of waiting until motivation happens, and the reality that often when doing an activity, the activity itself becomes reinforcing. For anxiety, when we think about behavior change, an important piece is exposure. And I think this is also important when considering programming, because there are certain kinds of anxiety disorders, like phobias, that really benefit from in vivo exposures that may or may not be possible depending on the environment that you're in. In a VA environment and working in PTSD, prolonged exposure therapy is a common approach. And prolonged exposure therapy combines imaginal exposure, so you're rehearsing engaging in a particular activity or going to a particular event, as well as rehearsing trauma memories. It combines that with in vivo exposure, where you are actually putting your body into a place where you may be experiencing distress. It's a safe place, but you're still putting your body into this place. And I, as a clinician, don't have to be there in order to have that engagement continue. However, there are some engagements, some exposures where the client is actually benefited by the presence of the provider. And so if you think about working with people who have hoarding disorder, who are actually not very likely to, sorry, I'm timing myself, that's what you hear, who are actually not very likely to go home and kind of clear out their spaces themselves, and they actually need some extra support. And so when you think about CBT, and the exposure pieces and how well it fits or doesn't fit into my environment, it's also important to consider resources, right? Who are we likely to be able to serve the best with this kind of intervention, given the resources and the capabilities of the communities in which we work and the organizations in which we work. Another thing that's important to note about exposure is that exposure is really designed to help increase client capacity for managing their own physiological distress. Often clients who experience phobias, for example, teach themselves, and PTSD, teach themselves unknowingly that the only way to deal with distress when they are exposed to a trigger is to avoid it, to run away. And that creates this feedback loop where a trigger is experienced, avoidance is the primary response. And what we do in exposure is we allow a client and encourage a client to utilize their tools to tolerate physiological distress, believing and knowing that that distress will eventually plateau and decrease if they stay in it long enough, and if they expose themselves to the innocuous trigger enough times. As we are rounding out this foundational discussion of CBT, does anyone have any questions before we move into a little bit more talking? Any important piece of the CBT foundation that you think is missing? I don't know what happened. Okay, what I say procrastination is exacerbated by anxiety using CBT. What is So when I think about procrastination, one of the things I really try to consider is how much procrastination is related to insecurity. And where are the client's insecurities? How much of the procrastination is about, well, here's a thing that I don't know how to do, or here's a thing that when I confronted it is bringing up uncomfortable emotions for me. And so, am I really working with a thought that's around the procrastination itself and the task itself? Or am I working with a thought that's more about my belief in my ability to tolerate uncomfortable emotions, my belief in my capacity to address areas where I don't necessarily feel that comfortable? How can I manage my own sense of insecurity? Is my insecurity telling me something true, right? Like, here's an area I really need more information. Is my insecurity telling me something that's not true? Like, I generally think that I'm not good enough. And so I often try to break procrastination down into its smaller parts to learn more about what the procrastination is communicating rather than focusing on the procrastination itself. I've had a few folks for whom it's really about time management, but for most of the people that I have worked with who are engaging around procrastination, it's usually about something else. And I apologize that I don't know what happened to my volume. So thank you for bearing with me. Okay, so the next piece is really beginning to think a bit more about what do we need in order to implement CBT well? What do we need at the provider level? And also, what do we need to think about at the organizational level? And so I'm going to reshare. All right. And this is leading us into a discussion around implementation science. Implementation science is really evaluating the methods for supporting integrating evidence-based practices into healthcare in order to improve the quality of care. And so implementation science says, okay, we can choose from A, B, C, or D for this particular behavioral health setting. If we choose A, what do we need in order to implement it in a way that is improving our quality of care, improving our outcomes, improving the experience of clients and others who are in that environment? And so we're really looking at not just the intervention itself, but whether or not that intervention is a good fit for improving the quality of care. And this looks different depending on the environments and the organizations that we're in. And I wanted to share this very short video that's really about aligning the tools with the task. Because we can have a great tool, but if the tool is not properly aligned, then it often creates more of a mess. And this video is not at all related to psychology. It's a totally separate thing. But I thought that it illustrated the importance of being very thoughtful about implementing in a good way.
Using the wrong tool for the job. Don't make the same mistake with HR and payroll.
Okay, so there we have the person who's using like a sort of mini drill in order to mix their coffee, another person who's using a fork for the soup, and a third person who's using a vacuum cleaner to gather their leaves or rake their lawn. Recognizing that there's nothing wrong with the tool itself, but the tool doesn't actually match the task. And sometimes the tool might match the task, but the tool doesn't match the environment, or the tool as it is doesn't match the environment. And there are some changes that might need to be made. And so as we transition into talking to each other, I want to introduce the first piece of program implementation that can be a place of exploration. And perfect. Okay, so I'm going to introduce, since we have 5 groups, I'd like each group to kind of tackle each set of questions. And maybe what we'll do is I'll show you the first set of questions, and if folks can kind of just jot down, because I'm not going to be able to show all four of the questions, all four of the questions in each group, because the questions are on different slides. And I'll show you what I mean in a moment. So the first set of questions is related to identifying the needs of the community and how we are identifying those needs. And so here are the questions for discussion. How do you know that your community needs this particular approach? How do you know that your community wants this particular approach? And have you assessed the needs of your community in the most comprehensive and inclusive way possible? So as you break into your smaller groups, and Stephanie's going to put you in your groups, I'd like you to think about your own organization, even if you're with people who are not a part of your organization. And you might not know all of the answers to these questions, but I'd like you to think about what you do know and to move from there. How do you know that the community needs CBT? How do you know they want it? And has your organization assessed the needs of the community in the most comprehensive and inclusive way possible? So Stephanie, if you can move people.
Yep. And how many
And
minutes?
I'll give you about 3-4 minutes to address this question. Welcome back. Today, we are going to talk about another piece of implementing behavioral health programs in mental health settings. Last week, we were talking about CBT, some of the foundational pieces of it, but also considering the way cognitive behavioral therapy may or may not fit with the particular environment of care that you are in. And I asked you to think about whether or not the communities that you are engaged in have requested, have knowledge about, are aware of the cognitive behavioral therapy interventions that they're being offered. And what this really means isn't so much that a client comes in and says, hey, I want to do CBT, because that's what I've heard of. But it's more about considering what are the needs of the population that you're working with, and how well does CBT fit with those needs, and who's making that determination. As trained professionals, many of us in counseling school, social work, and psychology programs were told that cognitive behavioral therapies are the gold standard treatments for a myriad of psychological disorders. And they are. But there is no one solution that fixes every problem everywhere for everyone in every context. And sometimes, even if that solution is effective, there are some modifications that are needed in order for it to fit better with the context in which it's being delivered. I asked you to consider these questions as you ended our workshop last week and went off into the world, and gave you a couple of tools to help you do that, to help you think through some of the questions that would be important when essentially conducting a needs assessment. And I'm wondering if anyone was here last week, did you get an opportunity to look at any of those tools, or to think more deeply about the fit between CBT and the environment of care in which you work? Anyone at all? And you're welcome to come off of mute and share. I see a couple of familiar faces and names. And if you were not able to do so, I do encourage you to spend time. There are some of us who are decision makers kind of at the top in administration and leadership, but clinicians are also decision makers. You are the ones who are on the front line. And so you really get to see firsthand how well something is working, how well something is fitting or not. And I encourage you to spend some time to step back and think about, here are these offerings that I have been trained in. How well do these offerings match the population that I'm working with? And if asked, what might the population I'm working with say they need, they want? and what's the fit here. So if you haven't had a chance to look at those tools and ask yourself those questions, I do encourage you to do so. I'm going to go ahead and share my screen as we begin the next part of our conversation today. Hopefully, my volume will last the whole time. I don't know what happened the last time we met. I lost volume some other time later in the day, but then I didn't have any trouble. Today, we are discussing measurement-based care. Is anyone familiar with measurement-based care? You can drop a yes or no in the chat. Anyone heard of it at all? No. We have one no. Anyone else? Okay. Yes.
Is this where we assess the effectiveness of the modality and look at the outcomes?
Yes. Measurement-based care, in short, is the integration of behavioral health measures or outcome measures within behavioral health settings. And it's looking at the progress or the process of the intervention across the lifespan of the intervention with a particular client. That might look like beginning the intervention with a pre-assessment and following up every week, every 2 weeks, every 3 weeks, using the same measures. Usually measurement-based care reflects symptom severity and really looking at the ways in which symptoms are changing over time. But we'll talk more about our thoughts about that, whether or not symptom severity and changes in symptoms is enough to really determine the quality of an intervention, or if we might want to expand how we're thinking about measuring. But yes, you're absolutely right. Integrating outcome measures into care. As we began last week, today I'd like to also start with a reflection. And this time, I'd like us to spend some time talking together about this. The first question I'd like you to sit with for a moment is, how do you know how your clients are functioning overall? How do you determine how they're functioning? Anyone can share. How do you know how your clients are functioning? When they walk in the door, you hand them a PHQ-9. Start sessions with, how are you today? How do you know? How are they doing? How do you know how they're doing?
So what I was thinking is, yes, when they walk through the door, also what they report to me, as well as listening for what they're saying and not saying. Like if I gave them homework, did they follow through? How was it for them? And then also how much their symptoms are impacting their life. Like, if somebody shares with me that it took them longer to get out of bed, I would know that their symptoms are have increased more than what maybe previously was going on. Or maybe this time it only took them an hour to get out of bed when it usually takes them 3 hours. So just kind of listening to what they're saying.
So lots of self-report, paying attention to what they're saying. I love that, what they're not saying. You're noticing changes in their functioning because you're remembering maybe last time they could pop out of bed, the last time we talked, but now it's taking them an hour, 2 hours, 3 hours. Something's going on, their functioning is changing. Absolutely. I saw a hand. Patricia? Was your hand still up from before? Or were you
Yeah,
asking a question?
yeah, I was essentially going to say, feedback from the consumer, similar to what the previous person, they're either going to tell you challenges that they've had,
Mhm.
or they're going to share with you accomplishments. They may say, that suggestion that you gave me in terms of journaling has really been helping me to reflect.
Okay.
Or they may say, I'm having some difficulties or some challenges with some suggestions that you may have provided.
Okay. And is most of this feedback happening verbally? Like what you see and also what they're telling you?
Well, for me, I like, I mean, you can observe things like in terms of how the person is presenting, or
Sure.
let's say they are, for some reason, you see that they're not keeping themselves up as maybe as they have been previously. You can assess from looking at them, but feedback, they will share struggles
Right.
and challenges that they're having. And they also will share accomplishments and what is or isn't working with for them.
And so a caveat to the first question is, how do you know how well or how poorly clients are responding to treatment? The first question is overall functioning. The second is more specifically, how do you know the CBT is working? How do you know that your approach is effective or not? How can you tell? Any ideas? Amanda, are you around? Sorry, I also teach, and so I am not beyond asking folks.
Well, I would say observation.
Okay.
You can also, let's say you have, and there, let's say a person has a challenge and you want to decrease the frequency of a behavior. And the fact that the behavior has been um, decreasing, or it's leveling off, or it's the same. You can tell from verbal, them articulating it
Mhm.
to you, and you also can tell from the frequency of whatever the behavior is that you're trying to address.
So getting very specific, if someone comes to me and they say, I am really having trouble quitting smoking, and I notice I smoke first thing in the morning, I smoke after every meal, and I smoke before I go to sleep. And they come back several weeks later and they say, you know what, doc, I've cut out smoking after every meal and I'm only smoking in the morning and in the evening. Then I know if my intervention was targeted towards ceasing or reducing their smoking behavior, if that behavior is changing, then I know for sure, more or less, that this intervention that's targeted towards this particular behavior is shifting that behavior. How do we know how clients are responding to us?
They're going to give you feedback. They're going to um, be open, or if they're open and they're excited about working with you, or if they're distant and withdrawn, that's how you tell.
Okay. So we're paying attention to the interpersonal experience, what that feels like being with them, how they seem to engage and respond to us. Are there any other ways we can tell how our client is responding to us or how well the therapeutic alliance is working?
My thing I notice is if they're missing appointments, canceling, not really coming, or making up excuses for not showing up. That's another
Absolutely.
thing in identifying what may be going on in the relationship.
Absolutely. Right. That sometimes clients aren't able to come because something comes up. Uh, they had to go to school to take care of something with their child. They ran late at work. They forgot when they scheduled. But if these occurrences seem to continue happening, then we might start to question, is this about the relationship, or is this about life circumstance, or is this about something else? Quality of relationship can even show up in ambivalence about treatment, that a client might feel like, I don't really know. I don't know if this will work for me. I don't know if this therapy thing is what I want. And sometimes that is an expression of concern about the intervention, but sometimes it's an expression of concern about trust in the relationship. So I'm asking these questions because I think it's important for us to consider how we are tracking client experience and client progress. And so far, what I'm hearing is that we are paying attention to how the interpersonal relationship feels. We are paying attention to particular symptoms or behaviors that we might be looking at. We're paying attention to client self-report. What I haven't yet heard a lot of is paying attention to objective measures. And that is something that we're going to spend some time talking about today. Oh, Carla, your hand is up. Yes?
Yeah, I was about to say that most of the time I mean, we have the clinical history of our clients. So it's very important for me at least to see where they started and where we are in the
Mhm.
moment that we're having the sessions. And when they share with me and I notice certain things about their mood, about what's going on in their lives right now, I like to assess as well, like how you've been sleeping, how you've been eating, like how do you feel right now? Like assessing all the time their sleeping habits, their eating habits, uh, their daily habits,
Mhm.
because they change all the time.
Mhm.
And also, like, if already know the diagnosis of my clients, still assessing on, the anxiety or for anxiety to see how their stress levels or anxiety levels are, or if they're dealing with depression constantly, not constantly, but when I see it properly, to do the questions of, are you having suicidal thoughts?
Mhm.
Are you thinking about self-harming? Um, and I don't know, I'll do it like more clinical thing to see
Mhm.
where they are.
And Carla, are you getting this feedback mostly verbally, or are you using outcome measures, self-report measures, or a combination?
I do it verbally, but most of the time I like to base on the DHSM-5.
Okay.
I would also do that. And for example, for most of my clients are dealing with anxiety,
Mhm.
depression. So I also like to do like the PH9Q,
Mhm.
like depression, and for the GAT7 for
Mhm.
anxiety.
Perfect. That is what we're talking about today. We're talking about utilizing all of the data that we can gather from our clients, including our interpersonal experiences, listening to their verbal feedback, watching their nonverbals, and integrating that with data that we can obtain from objective measures. As we begin to talk about measurement-based care, I want to contextualize it a little bit. Coming from the Center for Mental Health Implementation Support, there were kind of 8 core topics that were important for mental health organizations when considering implementing programs. And they ranged from engaging the community and assessing their mental health needs, which really gets to what I started talking about last week, identifying factors that influence implementation. Why are we implementing this particular program in this context at this time? Deciding what support is needed to implement, right? I asked this question, what do you need from clients? What do you need from clinicians? What do you need from leadership in order to implement CBT well? That was the question last week. Using clinical progress to guide treatment, which is really what Carla was talking about. Assessing sleep, assessing eating, assessing daily functioning, assessing depression, suicidal thoughts, and directing treatment according to what the person is describing. The other 2 folks who responded, you were also talking about paying attention to clinical progress. And the next step is integrating our observations about clinical progress into our treatment interventions. Marketing programs and services. Marketing is most successful when we're telling a good story. And good stories are at their best when they're backed up by data. When we have data from the interventions that we are implementing, that allows us to tell a coherent story, which then allows us to market our programs and services in a way that is honest and reflective and authentic. Using data to improve service delivery, that's exactly what measurement-based care is about. It also helps us to evaluate program outcomes and sustain service delivery. The ideal form of measurement-based care is that you not only administer measures, but you collect the data, you analyze the data, you turn the data into some digestible form of information that you can then utilize to inform your treatment decisions at an individual level, but also at a program level. And those kinds of iterations, that kind of responsiveness can actually allow service delivery to be sustained. How many of you use measures at the beginning of treatment with clients? Just drop in the chat, me. Just at the beginning. You might use a PHQ-9, a GAD-7, you might do a BDI, a PCL for those of you who are working with trauma. Okay. We have one person. How many of you use measures at any point in your practice with clients? Maybe you didn't do it at the beginning, but you do it at the end. For the first 4 weeks, okay? Anyone else? And how many of you consider outcome measures to be integral to your practice? That is just a part of what you do. We usually try and start with gathering baseline data. Okay. Okay. Patricia, are you just raising your hand or you have a question or comment?
No, I just want to say that's the whole point of engaging with the interventions to facilitate the client's success and to see some progress. That's the whole point. So you would measure. I mean, what in one instance we were using locus and CalLocus in order to evaluate the level of care that would be needed and see where the consumer was. And then at the end, an assessment tool would be used to see if they've reached the goals that were originally established at intake and to see what progress is made. It's just, to have some evidence-based data.
Yes, absolutely. That is exactly part of why we engage in measurement-based care, so that we have some evidence-driven data. And we also like to measure clinical progress throughout the intervention, beginning with the very first session. What is your baseline? And then after we have had 1 or 2 meetings, how are you responding to treatment? Because 1 or 2 meetings in is early enough for me to make adjustments, for me to know, is this working? Is this not working? Are you understanding? Are you not understanding? Is there something happening here that we haven't even talked about that I might need to pay attention to for our 3rd and our 4th meeting? And really paying attention to how can we measure clinical progress throughout the time that we're working with clients, rather just at the beginning, just at the end, or only not at all, or only using one type of data gathering. Certainly conversations are a way of gathering data, asking clients how they're doing, asking about the different life domains verbally. That's absolutely important data. Noticing nonverbals, all of that is really important data. It's just the next piece is having it on paper or on a computer, probably most likely in a cloud somewhere. Measurement-based care is the systematic evaluation of patient symptoms before or during each clinical encounter to inform behavioral health treatment. Now, for some environments, giving a measurement every single time you see a client might be untenable. And so I think it's important for us to think expansively about how can measurement-based care be implemented in your particular setting in a way that is doable, because the measurement-based care that we want is the kind that can be attained. And if the directive is to measure how your clients are doing every single time, and that is untenable, and so no one does it, then we're not effectively utilizing measurement-based care. If instead it's more tenable every other week or at particular markers within the course of treatment, it's important to be thoughtful about how does measurement-based care work in our particular environment of care. There are particular aspects of measurement-based care that are important to consider. One, it is an evidence-based practice. So we do know that measurement-based care improves client outcomes in many circumstances, that it also improves program delivery, improves sustainability. We'll talk a little bit more about how it does that. It also can improve the working alliance between provider and patient. It also can improve collaboration between providers, because now we just have a larger breadth of information. And it's also easier to send the results of a measure to a clinician who might not be working right in your environment than necessarily jumping on the phone and saying, hey, I had a conversation with this client and this is what they told me, as opposed to saying, hey, can you take a look at these numbers and tell me what you think? Measurement-based care uses systematic and routine assessment of the patient's perspective. It means it's built into the environment of care. This is how providers deliver care, whether they're using CBT, which I actually think is really well suited towards measurement-based care, or they're using other approaches. Building in outcome measures is just an expectation, a standard that providers are upholding. And it's also systematic. It's not random. I'm not choosing, well, maybe I'll give the measure in week 1, and then maybe in week 3, and maybe in week 6. There's some method to the madness, if you will. I'm giving the measurement every 2 weeks because I'm really wanting to pay attention to where we are every 2 weeks in terms of our goals. Or I'm giving it every week because I'm really trying to adjust quickly, especially if I'm utilizing a short-term treatment that has very specific targets. Or maybe I'm working with someone who is at very high risk and I need to know on a very regular basis how they're doing because I need to be able to assess their risk quickly and consistently. Measurement-based care also utilizes patient-reported progress and outcomes to assess symptoms and functioning. So it isn't just me looking at my patient or deciding how they're doing, I'm hearing from them. Measurement also occurs throughout the course of mental and behavioral health treatment, right? It's not a one and done kind of thing. It also informs treatment decisions and engages patients in their treatment. I think this last piece is really important because sometimes we can get the measure, give the measure to our clients, collect the information, and then it sits. It sits in a computer folder somewhere. It sits in an actual folder somewhere, collecting dust, and we only pull it out again when we have to write a report for funders, or maybe we're doing some research for something and we're trying to put together a presentation or an article. Measurement-based care says we need to bridge the gap between research and implementation. The data isn't just to gather and have and pull out every once in a while. The data is dynamic, is to be used in real time so that I got this information last week and it's the next week or 2 weeks later, and I am changing the way I'm doing treatment if that's what's indicated. Or maybe I'm doing things exactly the way I was doing it before, depending on what the data tells me. So this last piece of measurement-based care is really, really important for really being effective in your MBC approach. There are particular tasks of measurement-based care. The first is to regularly collect data that's related to patient symptoms and functioning. It's actually the second and third is to review the data as a provider and then to share it with clients. So I'm not just looking at the results of the PCL. I'm not just looking at the results of the PHQ-9. I'm looking at it first and then I'm sharing it. I'm saying, hey, Mr. Jones, when you first came in, your PCL-5, the score was at a 68. And after just a couple of sessions of prolonged exposure therapy, your score is now at a 56. We're doing it because we want to share progress and have clients actually see in real time. Sometimes clients may not understand or may not see how these changes are really happening for them. So having a visual can be super helpful. We're also doing it because paper tells us one thing. I've mentored many students who are working with trauma and they administer the PCL and then they tell me what the PCL says and I ask them more questions. Okay, so the PCL, your client said that they are feeling extremely distressed by re-experiencing. When are they re-experiencing this particular memory? I don't know because the PCL doesn't ask that. And so I'm asking my students to utilize what's on the page as a jumping off point, especially for those items that are endorsed high or with high severity. We want to know what is the broader experience here? When are they re-experiencing this particular memory? Is it triggered? Is it untriggered? How long does it take for them to recover from their experience of being triggered? I want more information. And so we're sharing results with clients, not only because we want them to see what we see, but we also want more information about what their symptoms really are at different points in time in terms of what their experience of their symptoms are. We also are doing this so we can continue to build trust in the relationship so that the clients know that we are on the same page. We are seeing them, we're seeing what they're saying and even what they're not saying, and that we're interested in modifying treatment and collaborating with them in their treatment journey. It really is a way of continuing to build rapport and the working alliance. And that really feeds into the fourth piece, which is the action piece, that we don't just allow the data to sit where it is, that we actually shift and change how we might be engaging in treatment, depending on what we're seeing. Here are the mechanisms of action that are thought to work in MBC, and this is kind of a visual that I picked up from the American Psychological Association, that we're engaging the patient. Hopefully, we want the patients to believe that filling out outcome measures is helpful for them, that it actually helps them and also helps us. By engaging the patient, we then are signaled as providers. We notice needs for action. We can notice where we might need to spend more or less time in our time with clients in the treatment. We notice where there might not be responses that we were hoping for. We can notice sudden declines or anything unexpected. We can also notice places of improvement and celebration. I like to celebrate my clients along the way. I like to help them celebrate themselves by noticing and being grateful for the progress that they're making before they might even reach their ultimate goal. The provider takes action. Again, I know I keep talking about the action piece, and I'm emphasizing it because often we might get the measurement part down. That might be fine. It's the acting. It's the being informed by the measurement such that we are actually modifying what we're doing. So ideally, we engage the patient. That gives us, the provider, information. It signals us to pay attention to different things, notice different things, which then allows us to take action. Any questions about this dynamic so far? Anything that I've talked about with measurement-based care? Stephanie, any questions that I'm missing?
I don't see anything additional in the chat.
Perfect. Okay. All right. So why do we use measurement-based care? Like, what's the big deal? Well, measurement-based care has been shown to improve client outcomes over just doing a one-time assessment. Doing the intake assessment is not enough. Continually assessing how our clients are doing, that has actually shown to improve the end result of why our clients are coming to us. It also can direct target selection in therapy. A client might say, you know what I'm really concerned about is my relationship with my mother. Okay. We also see, though, in their PHQ-9, or maybe we give them a BDI, that they have pretty moderate suicidal thoughts. And so we want to pay attention to that. So even though our clients are saying, I really want to talk about my relationship with my mother, we can also bring in, I hear that. And there's also this concern here that you've expressed. And I'd like to add that to our treatment plan, if that's okay. I'd like to ask my clients if it's okay when I want to add something to the treatment plan, because I do want them to know that this is a collaboration, that we are steering the ship together. When we have in black and white the feedback that our clients are giving us, it can really help to direct where we're going. It can allow us to identify change mechanisms, what's working for a client, what's not. It can also facilitate care coordination. Maybe I have a client who has come in, and again, they're talking to me about their relationship with their mom. Maybe I've seen them for about a month, but I notice on one of the measures that their sleep is changing. And maybe I either don't have time in my sessions to address sleep, or I'm not really a sleep expert, but I know a sleep expert. I know a sleep expert who is in my same organization, or maybe they're in an organization that my organization has a relationship with. Through these outcome measures, I can then say and identify, you know what, Mr. Jones, it looks like sleep is also a problem for you. And I'd like to refer you to Dr. Nancy, who really specializes in managing sleep. And Dr. Nancy can let you know kind of what's going on for you, and maybe she can help you get your sleep back on track. Measurement-based care also allows treatment to be responsive and collaborative. We are collaborating with one another, but we might also be collaborating with other providers. It decreases the cost of care, because if we are allowing ourselves as providers to be responsive to treatment, then it is possible that our treatment can be more relevant and more effective. It actually can be more comprehensive. So our clients are not necessarily just languishing in treatment that is not effective for them and kind of just cycling through and cycling through. it usually outperforms usual care. So if we think of treatment as usual as treatment that is not grounded in measurement, measurement-based care outperforms that particular approach. There's also a lower likelihood of patient deterioration because if we are regularly monitoring symptoms, it's much more likely that we're going to catch them. I recently had a client who I had been seeing for a long time. He discontinued treatment and then came back a year later. And this time I've been seeing him for a couple of months. And throughout our work together, I was able to observe how his functioning was declining, but it was also really helpful to have measures to also corroborate what I was seeing. Eventually, we did decide that he needed to go to a higher level of care, and he and I were on the same page, and I also brought in one of his trusted folks so we can all make that decision together, and we have the data to back that up. Some evidence also suggests that measurement-based care, some clinicians actually have more difficulty determining which clients might not be well suited for the intervention, and also which clients are more likely to deteriorate. I know I asked you to think last week about the fit between cognitive behavioral therapy and the population you're working with. And that's because if we are using the wrong tool for the right problem, then we may not be actually addressing the problem the way we need to. And not every tool works for everyone, even despite what the literature says. And so really paying attention to the ways in which measurement-based care can even inform which treatment approach we're using. Maybe I'm really well trained in cognitive behavioral therapy, but my client is really not responding. So that either means I need to maybe get other training, or maybe I need to refer my client to someone who really can address their needs through a DBT framework, for example, or can do specific trauma treatment with them that maybe I'm not trained in. Measurement-based care is also helpful at an organizational level because aggregate data can inform decisions at that level. If I am only looking at how one client is doing, that gives me information about how one client is doing. But if I have information about how a group of clients are doing, that isn't only about this particular person and their experience of symptoms. It is now about the population that I'm working with. And that can be really useful when I am making larger system-wide decisions. Data can also provide and support evidence-based practice if I'm putting together a report for funders, if I'm wanting to do research, if I'm wanting to shift policy. Data is super, super helpful for that. It's actually necessary. It also can inform decisions about population health. And of course, data is always wanted by funding bodies and other stakeholders. We can tell emotional stories all day, but if we don't have data to back it up, the stories ultimately are incomplete. Beyond just the clinical symptoms, measurement-based care has been shown to reduce dropout rates and lack of treatment response. It also seems to strengthen higher levels of engagement in treatment and show increased respect from treaters, that clients feel more respected because they are really pulled into kind of the back end of our clinical process. Measurement-based care has also been shown to strengthen the working alliance in therapy. And so while we can get a lot of information about how well our clients feel connected to us and to the process from their feedback that they're giving us, either verbally or non-verbally, about their attendance or lack of attendance, we also can learn about the strength of the relationship through measures and measurement-based care. There actually is an inventory called the Working Alliance Inventory, which is all about the clinical relationship. And that is something you can incorporate into your treatment process so you can kind of get real-time information. Because we also know that there is a power differential in the relationship between provider and client or patient. And there might be some things, some areas that they don't feel comfortable talking to providers about. And so one of the things that this measure allows is for clients to express themselves in a way that is not as direct as verbal confrontation. However, measurement-based care is often still utilized in kind of med management settings when it comes to behavioral care, and not necessarily as prevalent in settings that are providing psychotherapy. And it can be difficult to distinguish the mechanism of change or effectiveness in psychotherapy. Even if you're doing a CBT protocol to the book, there is still something about the therapeutic alliance. There's something about the quality of the clinical relationship that impacts treatment. And so measurement-based care does have some work to do in terms of looking at psychotherapy as an intervention in particular. And there was at least one study showing that measurement-based care can worsen outcomes for patients with personality disorders. So as I said before, every tool, even the best tools, don't work all the time for everyone in every circumstance in every situation. But measurement-based care does work a lot of the time, especially for many of the things that we care about as mental health providers. We've been talking more broadly about what measurement-based care is and thinking about it in terms of symptoms. I wanted us to get a little bit granular and think about how we can measure progress throughout the therapy relationship in ways that are not so much like a standardized measure, like the GAD-7, for example. And I wanted us to look at some therapy tools that are often utilized in cognitive behavioral therapy. And the first is the traditional cognitive conceptualization of a client and the client's problem. Now, this is not a measurement per se, but it is a formalized approach to breaking down what the client is struggling with. It's a way where we can begin to identify targets. It's a way where we can begin to build what the treatment plan is going to look like based on the information that we've gained from clients. And it's really important to have a picture, a framework, right? It's important to have the frame of the house before you fill it in. Otherwise, we might be measuring pieces of experience that are important but may not be priority, that might be present but not as relevant to treatment as some other pieces. So I wanted to start with the cognitive conceptualization, and you see these two different versions side by side because one is the traditional conceptualization and the other one is the strength-based conceptualization. I like to veer towards strength-based interventions for my clients because I believe that ultimately one of my jobs is to empower them to know that they can make changes in their lives, to know that they can rewrite their own stories and their own narratives, no matter what they've experienced. So beginning with a clear case conceptualization, and it's often helpful to have it written down. I work with a lot of students who have a conceptualization in mind, and they might talk to me about the conceptualization, but they haven't necessarily written it down. So I actually think that having a place where this conceptualization lives can be super helpful, especially when you're engaging in measurement-based care. Of course, tracking automatic thoughts, super helpful, allowing clients to engage in this process as well as providers. One of the pieces that I did not mention last week is that cognitive behavioral therapy was also designed to allow providers to be teachers and clients to be learners of their own experience so that they can be in the teacher role, meaning they can teach themselves. They can teach themselves the skills that they have learned in therapy. They can teach themselves how to shift their thoughts. They can teach themselves how to identify what needs to shift. And so having these worksheets, these automatic thought worksheets can allow you as a provider to track, okay, well, what are the thoughts that my client was dealing with, working with in the beginning, and how is this shifting or changing, and how are they able to identify their own automatic thoughts? Now, this is not a standardized measure. It's not a BDI, right, or a GAD-7. However, it is critically important for learning about clinical efficacy and understanding whether or not this particular approach is working for the client that you are engaged with. The next piece, thought record, which expands the automatic thought piece. This is really looking at whether or not a client is engaging in challenging their thought process. This is the rubric for allowing them to do that. So the first time a client fills out a thought record, you get to see this is where we're starting from. And as you continue in treatment, as the thought record hopefully changes, you are also able to identify, okay, so this is what's working, this is what's not working. Wait a minute, every time I ask the client to pick up facts, they just tell me more feelings, right? Or they just tell me more thoughts. They don't tell me facts. So they don't actually understand what's happening there. I need to go back and make sure that I explain this to them so they understand this particular piece of the intervention, so that the next time they go home and do the thought record, they are able to actually pull evidence as opposed to telling me other perceptions or feelings there, for example. And so again, although these are not standardized measures, they are really important to understanding clinical progress within the course of therapy. This is really hard to see, but it's an activity schedule. And an activity schedule is a way in which your client can identify what activities they are engaged in every day. And they can also identify the level of achievement and accomplishment that they have after they have engaged in particular activities. This allows the provider to get a sense of daily activities, and it also allows both provider and client to identify which of these activities actually bring you a sense of peace, contentment, joy, well-being, and which of these activities suck those feelings out of you. It's actually really helpful to do this together, to at least review it together, because sometimes clients might feel like, oh, I did nothing all day. But when they actually do the activity schedule, they recognize, oh, I washed the dishes, I did the laundry, I took the kids to school, I cooked once or twice. Maybe when I say I did nothing, I meant I didn't do any of the things I wanted to do, but it wasn't that I was doing nothing. So activity scheduling can also really give a picture of where a client is at a particular point in time. And so paying attention to how this activity schedule changes, including even their motivation to fill out something like this, is really important for understanding clinical progress. Most providers know what the SUDS level is. This is just kind of a quick example of the subjective units of distress. I actually use SUDS levels pretty often in my treatments, whether I'm using cognitive behavioral therapy or not, because I think it's a really teachable tool that clients can use for identifying the varying intensities of their own experiences and getting in touch with the varying intensities of their own experiences. And so as my clients become more skilled as being able to identify the intensity of experience, I am learning more about them clinically and learning more about how in touch they are with their own experience. Now, switching to kind of more formalized assessment tools. The PHQ-9, this is a really popular depression screener. It is short. It allows us to, at a bird's eye view, look at the major areas that are impacted in depression, and also at the end, at the bottom, although that's cut off, get a sense from the client's perspective how debilitating or how impairing the above mentioned items are for them. And so this is really easy to fill out. It takes 5 to 7 minutes, very quick to incorporate into your treatment. And the time frame is over the past 2 weeks. So it's not something that you have to fill out every time, but it's something that you still fill out pretty regularly in treatment. The Beck Depression Inventory, this is not an image of the actual inventory, but instead it is an image of the kind of factor analysis of the inventory. It really details the groupings of the items and the particular domain that those items are speaking to. So the cognitive domain, the affective domain, the somatic domain. So there are questions that are really about the cognitive functioning, the emotional functioning, and then what's happening physically for clients who are experiencing depression. It's another really great measure to use to assess how a client is doing on multiple domains. This is a measure that I think is more detailed than the PHQ-9. And I actually think of the PHQ-9 not as a diagnostic tool, but as a screener, as something that points me in the direction of gaining more information. I think of the BDI much more as a diagnostic tool because it is more symptom specific in terms of severity. And I just think it gives more information. So if I were diagnosing someone, I wouldn't use the PHQ-9 to do that. I would use measures more like the BDI. It is more time intensive, and so it might not be something that you use every session, but it is something that's good to use at the beginning of treatment and then at regular intervals throughout the treatment. Generalized anxiety disorder often is assessed with the GAD-7. It's a brief anxiety measure. I feel about the GAD-7 the way I feel about the PHQ-9, that it's a really good screener. It's a way of directing my attention to find out places where I might need more information or less information. But this is actually one of the tools that is recommended at the kind of evidence-based measurement level for measurement-based care. The Beck Anxiety Inventory, or the BAI, this is a more in-depth assessment. It is closer to the DSM-5 criteria and is much more of a diagnostic tool than just a screener. It allows you to get more information about what anxiety is looking like for folks, how severe it is, and I think the time frame is also 2 weeks. And so again, it's not something you have to give every time you meet with a client, but it is something that you give on a regular basis. For me, when I'm doing particular interventions, I may give several measures. When I was training on prolonged exposure therapy, we gave the PCL, the Working Alliance Inventory, and the BDI regularly. There was one other measure that we gave not as regularly, but those were 3 that were a part of the assessment. When I do EMDR, I give the dissociative experiences scale pretty regularly throughout the work, as well as the PCL. So you might find that you actually bundle some outcome measures together because you want a comprehensive view of how a client is doing in multiple domains. Here are some other tools. I didn't include all of the visuals, all of them, but these are common tools that are used in treatment. For substance use, we have the PROMIS alcohol use short form, 7 items, and it's looking at use over the past 30 days. The Audit C, I regularly use the Audit C. This also is a little bit more than a screener for alcohol use disorders. This is a little bit more diagnostic. And the Brief Assessment of Recovery Capital, I actually hadn't heard of this. It actually sounds very interesting. This is looking at folks who are in recovery, how much support essentially they have, or that's known as recovery capital, across 10 domains. And this assessment can really help providers and clients identify where they might need to shore up some of their recovery capital to make it more likely that they will meet their goals in recovery. Anxiety, of course, we've already gone over the GAD-7 and the BAI. For ADHD, the Adult ADHD Self-Report Scale is a highly recommended evidence-based measure that is used. For sleep, Insomnia Severity Index, PTSD, of course, the PCL-5. There is also the CSSR, I can't remember the Climber. No, that's the suicide scale. There's another PTSD scale, I can't think of it right this moment, that is often used. But the PCL-5 is shorter, it's a checklist. And so it's just easier to get through, but it actually is a pretty good diagnostic tool. I use it not only for diagnosis, but also as a way to get more information about particular symptoms. For child and adolescents, we have a couple of recommended measures. One is the Weiss Functional Impairment Rating Scale. This is a longer scale that's really looking at functional impairment in 6 domains. The Pediatric Symptom Checklist, which is a short questionnaire that helps providers assess the likelihood of any mental health disorder being present. So this is just kind of a screener. It's something that directs you to more assessments in particular domains if needed. And the Child and Adolescent Trauma Screen, which also is a brief measure that points you in the direction of possibly more information. So I've just thrown a lot of information at you. I want to just stop sharing for a moment and just connect. Questions, comments, thoughts? Any measures on there that folks are like, I've never even heard of that? Or anyone feeling like, sounds good, Dr. Green, but like, when are we going to have time to do all of this? What are thoughts? Or anyone feel like I'm so excited to incorporate these measures into my work? Oh, you're welcome, Carla. Yes, Patricia. And I think what you're talking about, Patricia, is an approach that many people use. Many organizations, they assess at the beginning. They might assess when the treatment plan is being revised, which might be 90 days. Sometimes it's longer than that. And then they assess at the end. And what measurement-based care is saying is that is a great way of learning about what's happening at the beginning, what's happening somewhere along the way in treatment, and what's happening at the end. And what we would like to do is have more information sooner. How can we build in outcome measures closer to when the treatment is happening? And so instead of at the beginning and somewhere in the middle, learning about how the client is responding 2 weeks in, how the client is responding 4 sessions in, so that as providers, we can shift, we can modify, we can move things that we might need to shift or modify or move while we still have some time left in treatment. So I think, Patricia, your approach is one that is probably very economical in terms of time and even resources and bandwidth. And what measurement-based care is asking is to expand the bandwidth around those measurements so that we're getting more information sooner, so that we can incorporate that information into the work of incorporating measurement-based care. I'll talk a bit about what some of the barriers are and also ways of thinking about possibly easing some of those barriers. You absolutely need data for funders. You need data to continue receiving the resources, and you need data to see how clients are doing. Measurement-based care says yes to those things and also to that piece in the middle. So how can we think about incorporating measures into the work in a way that doesn't actually add an increased burden? And it isn't just another thing to do, but it is something that is actually useful for the providers and also for the clients. Because ideally, the kind of measurement-based care interventions that work are the ones that people do. It is not actually helpful for someone to say, I think you need to assess your clients at every session, even if you see them for 12 sessions, and you need to analyze that information and include that in your documentation. Most providers are like, I don't have time to do that. Most administrators are like, I don't have time to do that, and I don't have the resources to hire somebody to do that. So if that's not reasonable, if that's not feasible, how can we think about what is possible, what is feasible? What are the ways in which we can utilize the resources that we already have? Are there ways in which we can have EHRs that already have outcome measures built in? And so as clients check in, for example, there are certain pop-ups that they then have to complete. Are there ways in which we can use brief measures to understand more about how our clients are doing and leave the longer measures maybe at the beginning, at the end, but really thinking broadly about how can this work in a way that works with what our demands are, what our resources are, and what our environment is. So yes, thank you for bringing all that up, Patricia. Okay. And that really leads us to thinking about this next piece, that in order to be successful, in order to really have measurement-based care be something that your organization uses and utilizes, what do you need? What do you need from clients? What do you need from clinicians? And what do you need from administrators? And I think this might be a time where we can break out a little bit and just chat. And so, okay. And I would like you all to think about, in order for, in your respective environments, in order for you to incorporate outcome measures or these assessments more regularly into care, what do you need from clients, from clinicians, and from administrators?